Welcome, welcome, welcome. This is Health Issues. I'm your host, Chris Sylvain, and we're thoroughly excited about this program today. It's part of a series that we've been doing on opioid medications and their use in the clinical practice, but also on the streets. We have an extremely distinguished guest, Dr. Hazem Eissa. Welcome, Doctor.
Thank you. Welcome.
Yeah, we appreciate having you. Look forward to from Ochsner Hospital, Ochsner Medical Center.
Correct.
Tell us a little bit about yourself.
I'm in pain management. I've been with Ochsner since 1998, and I practice out of the Baptist campus off of Napoleon Street. I trained in physical medicine and rehab, and I'm subspecialized and board certified in pain management.
Board certified in pain management.
And physical medicine rehab.
And we'll talk a little bit about that later. But the question then becomes, pain management is very hot in the news right now because, and you give us, we talked about that earlier, give us a little bit about the history. You were saying how before pain medications were widely prescribed, but it's changing.
So the pain management as a specialty is a unique specialty that's centered around evaluation, diagnosis, and treatment of various causes of pain. As you know, pain may be coming from various problems like cancer, arthritis, or herniated disc, for example. The pain management physician is either board eligible or board certified by the American Board of Medical Specialties, which is the governing board of all physicians in the United States with a variety of their specialties. The pain management physician trains at least for 5 years prior to being able to sit for that board exam, and the 5 years follows the medical school. So the 5 years will include 4 years of a residency program in either anesthesia, physical medicine, rehab, neurology or psychiatry, and 1 year fellowship afterwards. That's then and only then are they allowed to sit for that board. There are other physicians who say they are pain management doctors, and they open a practice that will basically prescribe medications, and sometimes they don't have any certificate to go towards that, or they will have a certificate from another governing body which is not defined or approved by the American Board of Medical Specialties.
Okay, so the American Board of Medical Specialties defines it's the large organization that's recognized as the certifier. That's for those that have gone through a residency, and so just like cardiology or
correct. And it accredits the residency program and accredits the fellowship program as well.
But there are I think it's the American Academy of Pain Management and the American Association of Pain Management. Now, that's two that happen to find on the internet, and I'm sure there's others that give certifications or whatever to physicians, but they're not recognized.
Yes, there are a few that I have knowledge of, but I'm not.
Yeah, right.
Yeah, I'm
that's
not
fine.
very well.
Okay, no, that's fine.
Yeah.
But I guess the point of it is, though, is that there's an accrediting body that is recognized, but you have other bodies out here that allows a physician to say that they're a pain management physician, and it's allowed.
Yes, yes, it is. I guess it's allowed since they are mentioning it. Yeah, but I would recommend, if you're going to seek advice for treatment from pain, to find a physician who has been trained in an accredited medical program in one of the specialties that I just mentioned: anesthesia, physical medicine, rehab, neurology, and or psychiatry, and preferably fellowship trained and board certified, or sometimes they're board eligible, because you can't sit for the board right away after you're finished.
Okay.
Because you have to take an oral exam first.
Okay. Now, but the thing too, the drugs that we're speaking about, and opioids, are mostly prescribed through other physicians, not even pain management physicians.
So that's a misconception, that pain management equals pain medicine. So just like a cardiologist is expected to check your heart and give you medications that will help your heart, but the primary care physician is the one prescribing these medications afterwards. Same thing with gastroenterologists. If you have a heartburn, you get your purple pill from a gastroenterologist, but afterwards, who continues writing that prescription is the primary care. It's the same thing with pain management. If medications are chosen for a patient to take on a regular basis, we will sometimes recommend these medications, and then it will continue through the primary care physician.
So basically, you would set the treatment plan, but the primary care physician would actually be the one.
Correct. And then we see them once every year or every 2 years if needed, or if the medication dosages or there's any suspicion of inappropriate usage of the medication, we would like to see him back and make a judgment right there.
Right. So defining pain management as a specialty is pretty complex then.
Yes.
Yeah.
Yes. And it's a young specialty. So in the 90s, they had some fellowships, but it became much more apparent and defined in the 2000s, since the year 2000.
So we're only talking about maybe the past 10, 15 years?
15 to 20 years.
15
maybe.
to 20 years, and that's the Board of Medical Specialties.
Correct.
Okay, that's because the Board of Medical Specialties have always had other specialties for years and years, but just recently they divvied out pain management.
Correct.
In a sense. Okay. Now, basically, tell us a little bit about what you do. Like you were saying, prescribing medications is not the main part. You have other things that you guys do to help people with chronic pain.
So when we see a patient, we evaluate them, and according to where the pain is coming from, there's things that we can do to help the patient. We can actually give them physical therapy or physical modalities like electric stimulation machines, for example, traction machines or braces and so forth. There is also topical medications that we can prescribe if the patient has problems, and they're usually as strong as the oral medications, but with less side effects. So you put them topical on the area that hurts and hope that would help them better. There is also the procedure aspect. We do a lot of interventions to help our patients' pain. So, for example, if you have spine pain from a herniated disc, we do epidurals, nerve blocks. If you have abdominal pain, we have other procedures we can do that we do under ultrasound guidance or under X-ray fluoroscopy guidance. There is Botox that we do for headaches and spasm in the neck, or in patients that had strokes previously and they have very tight muscles. We give them botulinum toxin. There's several brands on the market. Botox is one of them. Mm-hmm. We also treat compression fractures, like if somebody has a collapsed bone in their spine, we can actually put a balloon into the spine, expand that bone, and put some cement in it and glue it back together, so the patient's pain would improve tremendously, hopefully. And ultimately, if the patient has chronic, unrelenting pain, we can use something called a spinal cord stimulator, which we implant a battery that will sort of interrupt the pain signal from reaching the brain, so the patient would not know that they have pain coming from that area. There's also something called the drug delivery system, which is a pain pump, basically, which can accept various type of medications, including opioid medications, narcotics, numbing medicine, or other types of medicines, and it actually helps a lot with the pain, since the delivery is directly to the brain and spinal cord.
Awesome. So it's really an awesome array of tools that
Correct.
can be used as a specialist that can be used to help people that have pain, for the most part, other than using the narcotics.
Correct.
Okay, but and let's give an idea, I guess a general idea, not necessarily in your practice, but how many do you feel can be moved from the narcotic medications and to where one of these, a mixture of those, can be successful?
So let's start historically speaking.
Okay.
We discussed this before the show, that in the 90s, an article came out blaming doctors for not being liberal with pain medications and leaving patients suffer in pain. And the result of that, medical boards of the majority of states became very firm on doctors to be accepting the fact that they have to write pain medications. So the result was a lot of patients on opioid medications inappropriately. To recount or recap the 10 years from 1998 to 2008, I think they did another statistics and found out that there was a big problem with prescription drug addiction or dependence. There's a lot of deaths that resulted from the use of the medication, and the pendulum has swung totally the other way. And the governing bodies in pain management, the educational bodies, are actually recommending opioid to be conserved just for post-operative acute traumatic pain or severe unrelenting pain, and of course in terminal cancer pain. So that's where the opioids stand right now. You have to be very conservative, and there's so many things that you have to look into before you write a prescription, like have I tried other things that are not narcotic, and to make sure that the patients are not taking them inappropriately, or there's any divergence, dependence, tolerance, or addiction.
Okay, well, let's deal with this thing first about addiction, because I would say the vast majority, or the majority, won't be able to use the other modalities. The majority would be on opiate or narcotic medications for those with severe unrelenting pain. I guess that would be the one.
Correct. So for to take the patient off an opioid, it's very hard, especially if they've been on it for years. It has to come. The initiative has to be from the patient, and they have to be convinced that they're tolerant to the medication and they're just taking it to avoid having the withdrawal symptoms. Okay. So if the patient is convinced to do so, there are doctors that can help the patient handle or come off of that medication. In that, a lot of patients that accept to do so afterwards feel much better, because they were always dependent on that opioid that makes them drowsy and having a hard time focusing, doing their job, or taking care of their activities of daily livings. So I would recommend that a patient who has been on medication for a long time just take a deeper look, because they think that the medication is helping them, but are they taking it because it's really making the pain disappear, the one that they had before they started this medication, or is it they're just taking it because it makes them feel good, or if they don't take it, they're going to feel very bad? they're going to start having the withdrawal symptoms, which can be one of these symptoms: having goosebumps. You can have abdominal cramps or diarrhea. You can have irritability or being unable to sleep, insomnia, and restlessness. So if this is what we're dealing with, the patient needs to know that they're taking the medication because they're tolerant to it, and if they stop, they're going to have withdrawal symptoms. So let me go on to define things. So this is tolerance that I just mentioned. So a lot of the patients are actually tolerant and not addicts. So this is a...
They're not addicts.
Yeah, the message is for patients and doctors too. Like, you got to define, is what I'm seeing right now is an addict that's trying to take a medication, or the poor person in front of me is actually tolerant because they've been the victim of being on that medication for how many years.
They were just in a car wreck, or they just fell down.
Correct. And they've been on it for so many months or years, and now they cannot live without it. They cannot live without the medication.
That's different from an addict who can't live without it, but...
Yeah, these are... this is called psychological dependence or physical dependence. They're dependent on that medication, and they are. That's a compulsive behavior. Like, you know, I gotta have that cigarette to smoke it. I gotta have that pill, and they do every means possible to obtain the medication, and they usually misuse it and they run out early. That's the addict. And the intake is also in an inappropriate fashion. So they're not swallowing it, but they're taking it through other routes. So that's the addict. And if that person is in that situation, they probably should seek help and not try to obtain the medication from a physician.
Then they should see an addiction specialist.
Addiction specialist, yeah. You know, if you go to a physician and try to get these medications from them, and you know that you are an addict or you're using them inappropriately, you can actually harm that physician. You know, like if the physician is discovered that they were writing to somebody like this, the medical board can come back and say, you didn't suspect addiction, and it might raise a red flag. So, you know, I think...
Now, what's the difference between the addict and the person who's tolerant, though? The person who's tolerant, but they're seeking the medication also.
Yeah, they usually take the medication appropriately, and but they're not taking it for the pain that they usually had. They think they are. Like, let's say they had a knee pain for how many years from an injury, and they initially took the pain pills for that knee pain. Now they're still taking the pain medication. The knee pain is not changed. It doesn't change much.
Right.
But they're still taking the medication. And if they don't take the medication, they're going to feel worse. So they gotta have a 0 point and then see if they're going up from it or down from it.
But they will desire to take more of the medication because of the tolerance.
Not necessarily. Not necessarily.
But if they do, they could desire to take more. Go ahead.
I agree. Like the dosage, they will tell you that the medication, I need more for that.
But then they're still not an addict, though.
Correct.
Sounds like we're splitting hairs here to me.
It's not splitting hairs. There is a definite behavior of an addict versus a tolerant person, and also they will tend to mix. The addict will mix many medications, including illegal medications or drugs. So that would be your addict.
Okay.
And so there's also a third entity, which is diversion, where they take the medication and give it to someone else, and that's of course not acceptable.
True. Yeah, of course. Yeah. You
that's
can't.
Out of the.
Yeah, you can't. That's not even in the ballgame. No. Right. Or even mixing, other medications that aren't prescribed for them. Okay. But so kind of. But I mean, moving forward though. But the medications that are used though. The vast majority are using these medications. So for pain management, whether they're through specialists, board certified, or internal med, family practitioners, everybody. The method, the vast majority of patients to treat unrelenting severe pain, I guess, because that will be the one. You have people with sickle cell and wheelchairs and everything else like that. Still going to be these narcotic medications.
Correct.
Okay, now, other medications with it. I know your benzodiazepines, your alprazolams and diazepams and the PAMs.
Yeah.
All right. We're looking at it that they're commonly prescribed. Okay.
Correct.
All right. All around the country, along with narcotics and
Correct.
the so-called cocktails. They're commonly prescribed. At the same time, doctors have gone to prison for commonly prescribing them now.
Correct.
And then, but tell us a little bit about that. But from the board itself and the medical boards and everybody, they're saying that they shouldn't, but they're still commonly prescribed. Help me out.
Well, the soma specifically and the benzodiazepine enhances the hydrocodone, and that's the common mixture that they call Houston cocktail, or there's another one that's Las Vegas cocktail.
Right.
And these are if you look at forums of addicts online, you're going to see how they can enhance, and some of these people also are bragging of how much of a high they get when they combine these medications,
right.
Higher than heroin,
right.
which is quite scary. The soma as a muscle relaxer should not be used because there's other choices already in the market that are not addictive. Benzodiazepines are excellent muscle relaxers, but only for a very short period of time. This is one of the fastest medications that you can develop tolerance to. So the benzos should be maybe used for a short period of grief, or maybe post-operative in an area that you don't want a lot of muscle spasm because it might move a bone or something, or a screw that you put in. Otherwise, I would think the benzodiazepines should not be prescribed except by psychiatrists, like long-term.
But question though, it's correct, best practices.
Correct.
But the vast majority, these cocktails, they're commonly prescribed all around the country by various pain management physicians and regular physicians, and for the patient who's walking in who had a backache or severe unrelenting pain, and that's what's normally prescribed, what are they to do?
I really think it's the best thing is what we discussed earlier, to try to come off of this medication. The combination is not appropriate.
Okay, but I'm just saying from a patient standpoint. Say somebody with a third grade education, 12th grade education or whatever in there.
Try to seek advice from someone that would help them come off of this medication and get another choice of medications.
Okay, but all right, and I keep going back to that because I'm still looking at it from a patient standpoint. It's almost as if the best practices is from, and that may not be your area, but the best practice of doing that, attempting to turn a ship, with a spoon. You know what I mean? Because this is
there's a lot of masses on these medications already.
Yeah, the gates have already been released. Whenever it happened, and now you have millions of people that are on these drugs. You have thousands of doctors that are prescribing them liberally.
Yes.
You have millions of people taking them. Thousands of doctors are prescribing them liberally.
Correct.
And then the focus is, and the doctors are saying we can't get people off of them because, as you said, it's difficult to do it. The patients are like, I don't want to get off of it, and very few physicians are trained to help people get off, and
correct.
It's like it's a medical issue where, like, what's a patient to do? I don't know.
It's a very hard problem.
It's tough. All right, sticky wicket.
Tough, yeah.
Tough it out. Tough it out. Now, and we mentioned it earlier. Now, on the other side, the supply is limited now, because what happens is, through whether DEA, the distributors or whatever, they've limited the supply of the medications. So now, nobody can even get the medications unless they go to large chain pharmacies that have huge volume. You know what I mean? The way it's set up. So the smaller operations, they can't fill them anyway. And so you have people that are, so it shifts everybody to the larger places, large chains, and so the patient's really up a creek.
I'm not sure how to answer that last part because I don't know which pharmacies have less or more, but I've noticed some shortage in some of these medications, especially when the change in the acetaminophen level happened. A lot of the hydrocodone and oxycodone preparations that are mixed with acetaminophen, which is Tylenol, have changed, reduced the dose, and there's shortage, and a bunch of my patients are not able to find their dosing correctly. The other thing is the brand names. Some pharmacies are shifting away from specific brand names and only carrying one brand name, which becomes a problem as well.
So therefore, again, from the program, approaching it from a patient standpoint, patients that have severe chronic pain, they literally do. I mean, you have people in wheelchairs. These are people that can barely walk without the medication. They can't even they can't function at all.
So the best person to ask is somebody who works in the pharmacy board or in the medical board.
We'll leave that alone. That's a whole nother subject because that becomes the issue. Now, I know a lot about it and we talk about it, but that becomes an issue. But I think the driver then, and that's why we appreciate you guys on the program. We're doing a series on chronic pain. The issue then becomes, okay, these are best practices and this is what should happen. But moving the rest of the world to here, it's almost like trying to get people to eat right.
Correct.
You know what I mean?
That would be awesome.
That would be great if we can get people to stay off soft drinks and so forth.
And exercise and take charge of their own lives. I've seen a few examples where patients lost a considerable amount of weight and started going to the gymnasium and working out regularly. They were able to tolerate their pain better or manage their pain better without having to do any medication management. There is actually also a video that I've seen of a Marine that was injured and could not walk for the longest time and he gained a lot of weight, and he decided he was going to change his life, lost his weight and started exercising, and he was running, I think, very long distance afterwards.
Just a few more minutes. Is there a relationship? And we talked about this before. Just like it takes a lot of willpower to get off narcotic medications for pain management, is that the same thing as people getting off of soft drinks, burgers, and fries?
I'm not sure. I haven't tried coming off of medications. I never took them, so I don't know what to tell you. But it's very hard to come off of sweets, like carbs. It's like if an addiction is that bad or tolerance is that bad, it's a tough situation, I think.
Dr. Eissa, we appreciate you so much. Thank you for Ochsner Hospital. Chris Sylvain, I'm your host. You're on your own. Fight as hard as you can. But society must do better to help you out, and we will do everything we can to push. Thank you so much.
Thank you.
We appreciate it. Health issues.